So we can turn the device on immediately. So the device has LED showing that we are on the network, that we are loading the batteries or not. Be careful, the device has a switch. So if the switch is off, the device is not reloading the batteries. You have an on and off button and a standby button, including, of course, alarm mute and alpha dial, which is rotate and validate. So once you turn the device on, I've seen that it's very close to a ventilator architecture. So we have to do a couple of testing, proportional valves, oxygen cell, computer board. So all the tests having passed here, we can continue. And device is asking you, virtually it's the best when the device is warm, but you can perform an oxygen calibration. Oxygen calibration is always proposing you 2 calibration points. I warmly suggest you to always start with air, which is the most important from both of them. If you have to calibrate one, it has to be air. And you start calibrating. So device will take 30 seconds for stabilizing the air and perform a kind of zeroing, as 21% is the base. After this, we will go to oxygen, which will set the highest reference point, and then we can deduct from this the linearity between 21 and 100%. You exit, you do the oxygen test, and we are gone. It's good to calibrate when you can, but at least once a week. And as I told you, surely not with a patient connected. So you do it when the patient is disconnected or between patients. Good. Test is passed. We exit and we can skip. The screen is split in different sections, where you have the banner, the communication banner, displaying the setup. That might be a baby or a kit setup. We have a patient data management system, so we have the possibility to create the patient's file, which will be sent to by HL7 to the central monitoring. The situation of the battery, of course, and the timer, which is important for the PDMS and for the event log. The flow delivery devices that you have here are displaying how much air and oxygen are in use. That might be a little bit put in relationship to what we had before on the SNIPPAP devices, which are equivalent devices from other brands. But these ones are a bit different because they are displaying not the total air, the total gas mixture delivery, but the split oxygen and air delivery. So it has to be taken as a kind of information reference, but it's not a therapeutic information for the setting of the patient. So good feeling information, but less useful because we are going to use an automatic flow delivery, which was not the case in the past with previous non-invasive systems. The flow was constant, and we will develop later. This is the generators model displayed. So we have full compatibility with Quanda and Benveniste. So depending on the generator you're using, the behavior of the device will be slightly different. So important to use always the right generator with the right pitcher. The ventilation functions, where you have, as you can see, 3+1 ventilation modes, so constant pressure, mandatory ventilation, synchronized mandatory ventilation, and high flow nasal cannula, which is not ventilation, this is oxygen flow supportive mode. So we will develop respectively all these modes and their features later. And finally, you have the setup buttons where you can oxygen test, as I told you, and also auto oxygen calibration, which is something you can do during later on between the ventilation therapy of the patient. Also the maintain function, which is a restricted access to the biotech and to the advanced users for some fine tuning. when you are in the standby mode, you can take the current patient, which means that you are going to use the same ventilation setup. If you want to make a new patient, you start from scratch, which means that you would get back to a default setting of the ventilator. If we look at the trend, we can have the trend table or the trend graph. So the trend table would be values displayed. The trend graph would be values in a relationship to the time. The log files would show you all the events, which mean change of parameters, alarms, everything that has been activated or everything that has triggered something on the patient will be on the log file. The alarms would be, you understood that depending on the ventilation mode, the alarms that will be displayed here will be a selective alarm setting. You can, quick reminder, the sound, which is extremely important in neonatology. You can set the sound level, the indicate sounds, and the key sound volume, which is the sound that it's taking when I click on the button. So maybe this one we can also reduce. And the config. The config we might spend a little bit more time, because the setting is, I remind you, the setting, this is the way to activate the motion capsule, the motion sensor system, so the small Grace-B capsule. You have the O2 sensor monitoring on-off. Important, oxygen cells are depleting, and they are depleting most of the time when you are not expecting it. So it's not in the middle of the day, it might be in the middle of the night, it might be in the weekend. You might not have a reach of a biotechnical engineer for changing the oxygen cell. So you can choose to not have oxygen monitoring. This means that the device is mixing the gas by itself. We have an automatic mixing system. We don't need oxygen cell. The oxygen cell is there to alarm. If your oxygen cell is dead, you can decide to not have any alarm on the oxygen side, because you would have false alarm or you would have malfunctioning alarms. Oxygen cell not being active, it might stress everybody. By putting this off, is allowing to avoid false alarms. Once the problem is known, you can neglect it during a certain time. But of course, we have to replace the cell. Pressure units, you can express yourself in centimeter of water or millibars. Most of the time in centimeter of water. The funny part of the story is that we should speak in millimeter in Pascal. So we should normally display the pressure in pascals. And the trigger sensitivity, which is directly related to respiratory sensor monitoring, 10 being the highest sensitivity, 1 being the lowest sensitivity. So this also means that the sensitivity I would have in relationship to the movement is directly related to this number. Ventilator setting. Manual ventilation time. Remember, this is the bag that the manual ventilation. I can decide that the maximum time I would apply the high pressure level is 20 seconds. And the flush oxygen, we can also decide maximum 120, 30, 60, or 120. I advise you to let it at 120, knowing that you can activate and deactivate manually if needed. Pressure sensor calibration 0, this is maybe something more for the biotech department. This means decoupling the proximal sensing and zeroing the pressure sensor. I don't advise you to do it. Better to give it to a biotech department if it's needed. Screen brightness, clearly interesting when we are in a dark environment in neonatology. Time configure, I think this is clear. And software version, this is not really relevant for the clinical setup. It's going to speak about the ventilation mode, which are split into different big families. So NCPAP ventilation being a constant pressure ventilation mode, where we will have always the setting of FiO2, the CPAP, so the constant pressure setting, eventually apnea time, apnea pressure, and inspiratory time that we will be displaying in the second phase with the Grace-B capsule technology. So we will explain this a bit later in another section. The NIPPV is a alternating positive pressure without the synchronization of the patient. So it's alternating with a high, a low, and a high pressure. So what we call P-inspiratory inspiratory pressure is actually a high pressure phase, a low pressure phase being 4, and we are going to alternate these two pressure 30 times per minute. And this pressure of 8 centimeter of water is going to be applied eventually 1 second in this system. So that's NIPPV. So no interaction. We are just delivering constantly 2 level of pressure with a set frequency. SNIPPV would be the same setup, but with a synchronization, and this will be displayed in another section with the Gresby capsule too. And the high flow nasal cannula is actually just flow delivery with a high level of security, so setting FiO2 and a flow, and confirming would allow you to deliver the flow with high security, because we have a digital monitoring of the pressure in the main delivery line. So that's also very comfortable. So let's start. We can say that it's the end of one small micro section of this section. We are going to visit every ventilation mode separately from now on. So in NCPAP, as we said, we have a very easygoing two steps ventilation. So first, we are delivering simply the CPAP without having any added monitoring, or we can use a Gresby capsule. Gresby capsule, that's actually a kind of small air. It's a small air capsule that we are going to trap between the patient's thorax, between the thorax and the abdomen, so really on the edge. And we are going to use this as a pressure transducer to trigger. So we will know when the patient is breathing and try to, in some situation, trigger when we will get to the SNIPPV, for instance. And in the most passive ventilation mode, like the CPAP, we will count the breathing pattern. So this will allow us to alarm if the patient is insufficiently breathing, so speaking about bradypnea, or eventually not breathing at all, which is an apnea. For the need of the full demo, I will connect the Gresby capsule module, which is small box that will receive the pressure transducer that's here. Very important to know is that the capsule has to be placed on the patient before you place this into the box. So you need to place the capsule on the patient before connecting on the small box. When we connect this capsule, we can, in the config mode, we can go to config mode and say that we want to activate the respiration sensor monitor. If this is not activated, these 3 boxes will remain great. Great means simply that it's deactivated, so you can see them, but you cannot work with them. If I activate the sensor module box, they are getting bluish, which means that you can work with. So now that I have activated, we can set a patient. Let's say that we want to work with air, which is always fine. Set a pressure of 5. We can set an apnea time of minimum 10, which might change in the future. So this is maybe something we have to revisit later on. Apnea time, so apnea pressure, which is in case the patient is in apnea for 10 seconds, what would be the reaction of the device? Well, the reaction of the device would be to give a bit more pressure during a certain time. So this is what we call a burst. This is a kind of stimulus. So if the patient is not breathing, what would be your reaction if you had no ventilator? You would eventually gently push the baby to wake him up, or to give him a kind of incentive or stimulus. If the patient is in incubator and there is no nurse in the close surrounding, and the device is seeing what is happening, the best way for the device is to give a stimulus by increasing a little bit the pressure during a certain time. This is what is going to happen. We will simulate, because now, if I activate the capsule, if I don't show a breathing pattern by pushing on the capsule, well, you will have directly an apnea alarm. I start ventilation, as I've set what is needed. We will show in another section how to connect the generator on the baby's face. And here are we busy with ventilating. So you can see the pressure curve, the pressure time function, where not too much shall happen. And I already have an apnea because I was not simulating a breathing. If I want to simulate a breathing, I have to simulate by pressing on the capsule, and then you will see that we are estimating now a breathing frequency. So this breathing frequency, if I stop pushing on the capsule, if the patient stops breathing, I will get immediately in the apnea phase once I reach the threshold of 10 seconds. In the meantime, we can see that, see? So this is the apnea alarm. So I will shut it down for the moment during the demo. We can see here on the monitoring that we set 5, we measure 5. You see? We set 5, we measure 5. So this is the monitoring screen. So what we are displaying here is measured. It's a control of what you have set. So we are measuring 20% of oxygen, which is a little bit drifting from the 21 here, which means that, frankly, when we calibrated the oxygen cell, the device was still cold. It's always advised to wait a little bit, something like 20 minutes before to calibrate. So actually you have a small bias here. This is okay, but you might have to recalibrate once the device is warm. The flow that we are displaying is directly in relationship with the patient's leak conditions, the pressure that you have set, and the generator that you have chosen. So a different generator, different pressure, different flow for reaching the same pressure. If the patient has some leaks, of course, this flow will vary. So we are using 9.3 or 4 here, liters per minute for reaching this 5 centimeter of water. You can also see that as I'm using air to ventilate, I'm using only 9.3 liters per minute of air and nothing in oxygen, so 0 is displayed. So be careful, these 2 rotometers are not the same purpose than what you had on SNIPPV. And it's not even the same meaning than what you have on Fabian devices. So this meaning is quite different from the others. Well, this is CPAP. So as you can see, very easy. So every time you are in a ventilation mode, and you change something, you change your ventilation mode, you have to confirm. And the CPAP is extremely simple, so you only have a few parameters reachable in the setting box. Important to notice is that you will always have on all the screens, most of the screens, you will have manual ventilation and flush. So what does it mean? The flush is a quantity of oxygen you might give as a chemical stimulus. We were speaking about the burst, which is an automatic stimulus from the device when the patient is in apnea. If the nurse notices that the patient is falling, the SpO2 is crashing, the nurse can say that she wants to have a shortcut between 21% and let's say 50%, so that when she finds it's necessary, she will give an extra concentration dose of oxygen to the patient during a certain time that you are seeing displayed here. So we start to 120 seconds in this case, a countdown. We give 50% and the device is coming back to 21%. You can deactivate it at any time. If the burst of the device is not sufficient, you might apply a manual ventilation. What is manual ventilation? What the device was programmed to do here, you can activate it and require it manually. So this would mean that I would now apply, according to the time I'm pushing on the button, I would apply a higher pressure level during the time I'm pushing on the button. Actually, this would be a kind of manual NIPPV that we are going to see very soon. Important to note also is you have the monitoring information in quite big font. But you also have smaller figures here, 8 and 3, and 26 and 18, which are the alarm frames for the set. So when you set 5 centimeters of water of pressure, the device is immediately taking +3 and -2 as alarm frames. So if you want to set these alarms, we can go to the alarm function, and you can see that on the ventilator tab, you would have high limit, low limit of pressure, high limit, low limit of oxygen, and alarm delay. What is alarm delay? Alarm delay is reacting only after the 10 seconds that the alarm has been violated. So if I am under 3 centimeters of water due to a big leak for 10 seconds, only then the alarm would react. It's quite important for spontaneously breathing babies because they are living patients. So leaks can appear and disappear, and it's always good to have a temporized alarm. If you don't have temporized alarms, you will immediately have alarms, and nurses would be completely lost in an ocean of alarms. So very important to wait 10 seconds, or eventually a little bit less, but 10 seconds is a quite good average time, so that when you hear an alarm, this means that the problem has been lasting for 10 seconds. So again, everything is automatic. If you don't want to get it automatic, you can just go on the alarms and set it by yourself. Well, so what is done for the moment is that I will go to NIPPV, confirm, and we would have exactly the same kind of curves you have in IPPV, but with a mask, with a generator that would be here a Quanda style generator. We set PEEP 5, inspiratory pressure 8, inspiratory time would be probably shorter. I would place it probably in the 450 milliseconds, and the rate might have to be a bit higher too. And you can see the curves according to the setting. What is important to see is that you are well reaching the pressure. So the pressures you are setting here of 8, you have well to be sure that you're reaching this peak. You have seen that the monitoring also changed according to the NCPAP. NCPAP is much easier, so now we have the peak pressure, which is the highest, the highest pressure, the PEEP, which is the low pressure, and the P-mean, which is an averaging of the pressure during the last 60 seconds. You have no alarms on the P-mean, but you find back a high pressure alarm on the P-peak. It's not a CPAP anymore. So when we had alarms on the CPAP, we had an automatic setting above and under the CPAP on one parameter. Now we are going to take the inspiratory pressure 8 and take +3 on the 8, which is 11 here, and the PEEP -2, which would give you 3. So we are just separating, doubling the CPAP so that we are setting the alarms a bit differently. You also notice that we have a I/E ratio. This is not a correct I/E ratio. It's a proportion of inspiratory and expiratory phase. It's not a physiological I/E ratio. The patient is free to breathe on these cycles actually. But if the frequency is high, like it is in this system, if the frequency is high, we can estimate that the patient will follow the rhythm of the device. Here, you would notice that capsule is not useful. So the capsule is not useful. There is no breathing frequency because you are imposing the frequency. The frequency is 45 and it's going to be 45 all the time. So no interaction with the patient here. So NCPAP is monitoring, NIPPV is not monitoring, it's imposing. So quite easy. Important to know that the device is still compensating, and it's compensating on the PEEP side, so the baseline is guaranteed. The manual ventilation doesn't really make sense here, neither, because the manual ventilation is systematically set on the NIPPV mode. But the flush is well active, so if you want to give more oxygen, you can. Here in NIPPV, you will notice that the flow meters have changed. In CPAP, we had these two flow meters and they were displaying air and oxygen. Here you will see that we are displaying pressure high, pressure low. Actually, this is flow high, flow low, but we are displaying here the flows that we are using for reaching 12 liters per minute for reaching 8 and 9 liters per minute for reaching 5. So this is comparable to a CPAP flow meter or to a Fabian flow meter equivalent. So be careful, when I am in NCPAP, I am displaying oxygen and air. When I am in NIPPV, I am displaying mixture flows for the two different pressure levels. Well, as I have activated the pressure sensor, I have deactivated the pressure sensor, so I have to activate the pressure sensor. I can go to SNIPPV. Okay, now the SNIPPV is a very particular mode because I have, as you can see, we are applying a CPAP, but the device will only give a higher pressure ventilation if the patient is breathing by himself. In other words, it's a full triggered IPPV, hence the name, synchronized non-invasive intermittent pressure ventilation. So if the patient is stopping breathing, you would still have, in the extra setting, you would still have an apnea time, which is 10 seconds. You see that nothing is happening for the moment. And now the device is alarming and coming back to an NIPPV mode. So this is what we call a backup ventilation. Backup, not a burst. The device is imposing now the frequency that you have preset to avoid the patient to go in a much longer apnea phase. If the patient is breathing again, the patient comes back to a full synchronized system. So this means that also if he starts breathing and stopping breathing again for 10 seconds, the device will come back in a backup mode with alarming and so on. So it's an everlasting story. You can see on the monitoring that it looks like pretty much like an IPPV. You will still notice that here we are displaying the respiratory frequency, because here we need to see what is the frequency the patient is doing by himself. I'm triggering again, and the respiratory frequency here will be much higher than what I have set in extra setting, which was 45. Okay, last ventilation modality. This is high flow nasal cannula. We have different nasal cannula compatibility. Actually, any cannula is compatible with the WILAflow Elite. I am going to show you the interaction of the device with the different nasal cannula systems. So let's say that I'm using air, setting a flow. We have a rule of, let's say, 2 liters per minute by kilo in neonatology. So if I'm setting a flow of 8 liters per minute, which is already becoming red here, reddish, because of course 4 kilograms for neonatal department is already a big patient. So 8 is warning you that it's quite a high flow. You can see that we can go up to 20 liters per minute, which would be equivalent to 10 kilograms patient. Let's challenge 8 liters per minute. With this small nasal cannula, I confirm and start high flow. Strange thing on this device is that we are displaying a pressure. So this pressure is displayed on the screen, and it's not based on the proximal pressure sensing that you are having on the device itself. We will display it easily, take the pressure sensing line, and you still have a pressure measured on the screen. It's simply due to the fact that somewhere in the configuration, we can ask to the device to measure the pressure to the patient from the proximal line or inside the inspiratory line. So what we do have is in high flow, it's a pressure measurement in the inspiratory limb. What is important to know here is that the pressure you will be measuring in high flow nasal cannula on the WILAflow Elite is not patient-related pressure. The high flow oxygen therapy is not pressure targeted. So what we are measuring here is the pressure that's built in the circuit here up to the nasal cannula there. And the pressure we measure here is called the back pressure. So this means that it will be the pressure that will be generated by the device to push the flow through the nasal cannula. What does it mean? It means that if the resistance of the cannula is changing, if I'm kinking the one of the prongs, you would see the pressure changing. You see? It's not the patient breathing, it's the resistance varying due to the squeezing effect I'm doing on the prong. If I'm increasing the resistance much too high, which might happen, you would reach too high pressure, too high back pressure, and the device would stop. So on many systems, you have pop-off valves and security systems that are acting but silently. Here, the beauty of this high flow nasal mode is that you are displaying the technical pressure that would justify the pop-off valves, the pressure relief valves of other systems for opening. But we are stopping the flow when we reach the threshold. We are alarming and we are displaying what is the reason of the problem, because you see what is the problem. So it's extremely clear to use this system, extremely safe. And there is less misunderstanding also when you start ventilation, because you set the nasal cannula on the system before starting ventilating the baby. And you can see the systemic configuration before to place the baby on the system. So again, very safe and very nice mode to shift from one ventilation mode to high flow, and from high flow eventually back to CPAP or DuoPAP or SNIPPV. Because actually we are using the same circuit. So the ease of connection would be to pass from a CPAP system directly to a nasal cannula system.